I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge topics of medicine to the tri-state community in Staten Island. I'd like to welcome all of my viewers, and we have a tremendous guest here tonight. We're going to be talking about head and neck issues, and we have models to show it. And I'm going to introduce Dr. Sivarajah, who's at Richmond University Medical Center. We are both colleagues in the hospital. And we've spoken, she's been telling me about some very interesting new things that are going on in the world of head and neck. So head and neck's a big place.
Yes, it is.
So let's start from the beginning. How do you become a head and neck surgeon?
Good question. So after 4 years of medical school training, you will match to an otolaryngology head and neck surgery residency program.
So otolaryngology is an
ENT. Yeah, ear, nose, and throat. So the residency program is 5 years in total, and after that, if you choose to become a head and neck surgeon, meaning a head and neck cancer specialist or oncologist, you will do a fellowship in head and neck surgical oncology. That usually is 1 year. Some of them can be 2 years. And most head and neck fellowships these days offer microvascular reconstruction training. So you do become a plastic/microvascular reconstruction out of your head and neck oncology training.
Where did you train?
Yeah, so I did 4 years of medical school in London, Ontario, so I'm a Canadian. And then I did 5 years of residency at the University of Alberta in Edmonton, Alberta. Then I did 2 separate fellowships in head and neck surgical oncology and microvascular reconstruction. So the first one was at Massachusetts Eye and Ear in Boston, affiliated with Harvard University. And then the second one was in Charleston, South Carolina, with the South Carolina Sarah Cannon Fellowship.
Well, that's marvelous and tremendous training. So when we think of, when our viewers think about someone going for a head and neck surgery or seeing a head and neck surgeon, there's a tremendous fear.
Yeah.
We've seen radical surgeries of the past, and I think we spoke a little bit earlier, is everything that you do cancer? Mm-hmm. And the answer you said is no, and that really impressed me. But let's talk about, how does someone get to a head and neck surgeon?
Yeah, so there are multiple avenues that you can get to a head and neck surgeon, and I think it largely depends on what your medical issue is. We get a lot of referrals from family doctors and primary practitioners. And then we also do get referrals from cardiologists, pulmonologists, endocrinologists, if you're seeing them for thyroid or parathyroid
So
issues.
Why would someone be referred? Why would a heart doctor send someone to you?
Any number of reasons. So sometimes patients who undergo cardiac surgery can have a subsequent complication of dysphagia, meaning difficulty swallowing. A cardiologist or a pulmonologist may also refer patients if they know that they have sleep apnea. So I just recently started offering Inspire implantation, which is a medical device that is implanted within you to treat sleep apnea. So a lot of our referral base now is coming from cardiologists and pulmonologists for sleep apnea. And then endocrinologists see patients for thyroid or parathyroid issues, so they will send patients for surgical intervention regarding that. We get referrals from dermatologists for skin lesions, whether those be benign or cancerous. And so I've done a couple of skin cancer cases with challenging reconstruction this past year at Rumsey. So any number of avenues can bring you to a head and neck surgeon.
So tell me about lumps and bumps. So if somebody's home and they feel something on their head, should they go to a head and neck surgeon first? What should they do? I mean, people have, and they come to me, I'm a neurologist. So and sometimes I try to tell my patients, I really don't take care of the scalp, I take care of what's inside your head. And if you feel it, that tells you it's not the brain, that's a good thing. So when they feel a lump, a bump, back behind the ear, some common places where we oftentimes will find, and subsequently turn out to be an enlarged lymph node or a calcified lymph node. So does that bring you to a head and neck surgeon or bring you to an internist?
Yeah, I mean, there's no right or wrong answer to that. I think it can certainly bring you to a head and neck surgeon as long as the workup is being done to determine whether or not this is something that requires surgery or not. And I am, myself and my work partner, Dr. Lisi, are more than happy to do that workup if people want to refer patients to us. As long as we determine with the patient whether or not this is an urgent matter that needs to be surgically intervened sooner rather than later, or if this is something that can be watched, it does not matter who does the workup, really.
But when should people be worried? I mean, everyone's got little lumps and bumps throughout their body.
Yeah.
And you guys are the head and neck portion of it.
Yeah.
And especially with the neck, I mean, as we said, there are a lot of lymph nodes. People, after they're sick, sometimes people just feel a lump. Do most of those patients have something bad? How worried should people be? And what should lead them to even go to their regular doctor?
So I would qualify this by saying most lumps and bumps are not bad. There are certain characteristics that we look at to determine if something is bad or something we should worry about. So first is, how long has it been there for? What is the size of this thing? Where is it arising from? Is it bleeding? Is it impinging or causing pressure on nearby critical structures? So what kind of functional deficits is this patient suffering from? Is it associated with constitutional symptoms like fevers or weight loss? So those are some of the things that we look at. And then the next step would be getting proper imaging to see what this thing is and whether it is involving certain structures, and that would determine whether or not this patient needs a biopsy and surgery to get it removed.
So it's never wrong to do that?
No, absolutely not.
Okay.
Yeah.
So let's talk about the procedures in the past. When I was in medical school in my residency days, I still see patients coming into my office who've had, whether it's throat cancer or tongue cancer or different oral type cancers, have these very radical procedures that were actually called radical dissections or surgical procedures, and you sort of see a tremendous disfiguration. And now when I've had, whether it's colleagues, friends, or just been in the hospital on consultation, see that after surgery for the same kinds of cancer, the procedures are much less scary, much less disfiguring. People do much better with them. They're able to function much better. And they don't stick out, and they really don't have the stigma associated with them and the functional decline with it. So tell me the evolution, how we got from the idea that if you had cancer of your tongue or throat or other parts of your mouth and throat, they went from taking a lot out to now taking less out. Yeah,
that's a great question. And in fact, there's a book that I read recently that did go on the history of the evolution of cancer and cancer treatments. So what you were referring to, radical neck dissections, I'll preface this by explaining what a neck dissection is. So a neck dissection is performed for lymph nodes, to remove lymph nodes, because lymph nodes within our neck are usually the first station or echelon that the cancer will spread to before it becomes what we refer to as distant metastasis. So if you have cancer involving your lymph nodes, it does upstage your cancer, but it is still curable by surgery when we offer a neck dissection. Now, in the past, they used to perform radical neck dissections, which means they removed the lymph nodes, but then they also ended up removing the sternocleidomastoid muscle, which is this muscle you see here. They would potentially remove the spinal accessory nerve, which is the cranial nerve that controls our shoulder movement, and they would also remove the internal jugular vein, which is a huge vessel in the neck that drains the head of blood back to the heart. So now we're able to get away by doing selective neck dissections in the vast majority of patients. I will say sometimes we do still have to perform radical neck dissections, but that's only in very, very advanced head and neck tumors. But now we can do selective neck dissections without sacrificing those structures that I mentioned, thereby limiting the deficits that you leave the patient with. Now, with respect to the other surgeries that you mentioned, so cancers of the mouth, the tongue, the throat, it really does depend on how advanced we're catching these patients at. So we are very cautious about performing these surgeries because, of course, the first goal is to do an oncologic resection, meaning you want to remove the tumor, but you also want to do it with a normal cuff of tissue around the tumor so that you're obtaining negative margins. But you also want to do it in a very mindful way so that you're not leaving the patient with these huge deficits. The second part to this answer comes from the reconstruction. We've made large advances in how we are able to reconstruct these defects. So as I mentioned before, I'm a microvascular reconstructive surgeon, meaning I'm specialized in doing free tissue transfer surgery. So this involves me harvesting autologous composite pieces of tissue from various parts of the body, whether that's the forearm, the leg. I can harvest pieces of bone from various parts of the body. And it's sort of like a transplant surgery because we connect those vessels of those pieces of the body to vessels in the neck to allow those pieces of tissue to survive on its own. And by doing that, we're able to rebuild really anything. We can rebuild the jaw, we can rebuild the tongue, parts of the cheek, the throat, the voice box, the throat itself I've been able to rebuild. So these are all things that we can do with these new advances in reconstruction.
So you can get a functional benefit and people look better and feel more comfortable about what's going on.
Absolutely.
Tell me about the prognosis for people with head and neck cancers. Has that changed over the years?
It definitely has. I think the biggest thing that has changed the prognosis is our recognition of the human papillomavirus, or HPV, as it pertains to throat cancers. So HPV can cause throat cancers. Traditionally speaking, most throat cancers were caused by heavy smoking and heavy alcohol use, but we're finding a subset of younger patients with no smoking exposure or no heavy alcohol exposure developing throat cancers because it's caused by the HPV virus. And those subset of patients respond extremely well to radiation and chemotherapy. And so because we're able to provide those treatments, the prognosis for throat cancer specifically has gone up quite a bit.
So that's a virtue of the vaccine now.
Virtue of the vaccine as well, yeah.
So it's important to know that there is an HPV vaccine that can hopefully prevent those type of cancers.
Absolutely, yeah. And then the global rates of smoking and alcohol use have dropped, so the incidence of head and neck cancers is dropping, which is good. And then I would also say that there are newer classes of medications as well that have helped with the prognosis of head and neck cancer. So immunotherapy is a newer class of medications that helps the immune system find, target, and destroy cancer cells. And immunotherapy has revolutionized the way that we treat skin cancers. We're seeing a huge reduction in the burden of disease and a huge improvement in survival for patients with very, very advanced skin cancers that may not be amenable to surgery. We're also seeing immunotherapy used in patients with very advanced or metastatic head and neck cancers, and it is improving survival, albeit maybe a few months to a few years, but that's still a significant amount for someone in that condition.
So for everyone, immunotherapy is a different kind of treatment where your immune system attacks the tumor rather than chemotherapy, which attacks all dividing tissue that we have.
Exactly, yeah.
So I see you have some models. And I'd be remiss not to use the models. Because it's a tremendous education for myself. I see that model's missing some teeth. But maybe you could just show us what we have. And I think that would make us all a little bit more aware of really how big our tongue is and how large our tongue is and where things could be noted. And back to that whole thing that you said before, and maybe we'll say that more in closing, is that if you have a lump anywhere in your mouth or your throat, a lot of times your dentist will look for it, but you could feel it more often than somebody else could see it. And if that's the case, knowing that there are doctors that can help you look at it, biopsy it without major surgical procedures just to see what it is tremendous, and that's really also helping people live longer. So tell us a little bit about what we see.
Yeah, this is a general model of the head and neck. So it's sliced in a way such that you can see sort of the internal working components of head and neck anatomy. So this is the nasal cavity. All of this is, everything that this model is showing is things that we would treat. So this is the nasal cavity, this is the nasopharynx, which is where the back of the nose meets the throat. This is the tongue, which people don't often realize, how big the tongue is, how big the organ is. And then the voice box lives here. These are the cartilaginous framework of the voice box. We also treat diseases of the upper esophagus, the cervical esophagus, which lives behind the voice box. And so this model just kind of helps elaborate. We treat diseases of the mandible, we treat diseases of the sinuses. This model just kind of elaborates
mandible is
everything
the jaw,
that we
the
do.
sinuses, or the
jaw.
sinuses.
Yeah.
So we see different structures.
Yeah.
So when you have sinus pathology, you're talking about your ear, nose, and throat specialist, but the head and neck surgeon, usually if there's something major there.
If there's something cancerous there, then we would get involved. Yeah.
So we have a lot of structures that you went over. And I think you actually mentioned that a few moments ago, the thyroid and the parathyroid, which is right. Parathyroid just means around the thyroid.
Yeah.
Those are glands. That produce different hormones and have certain effects on the body. And thyroid, everybody knows about their thyroid, and there's so many people who have nodules in their thyroid.
Yes.
So let's go to something that's very common, and everyone who's watching us will say, I have a family member, I was told by my internist, neurologist, whoever it is, especially if they're doing some type of an ultrasound of their neck, that they've got a thyroid nodule.
Yes.
How worried should they be, and what should they do?
They should not be worried, first of all. So a lot of people have thyroid nodules walking around unaware. And having a nodule does not mean you have to be worried. But, if the ultrasound shows that the nodule has certain characteristics or has met a certain size criteria, and we have very specific criteria that we follow, if it meets those indications, then we would send you for what is called a fine needle aspiration biopsy.
And who does that?
Anyone can do that. A head and neck surgeon can do that. We could also send patients to a pathologist to do it, or interventional radiologists. They can do it as well, as long as you have an ultrasound, because it has to be ultrasound guided. And so we just await the biopsy results. And I will say, the most common type of thyroid cancer is papillary thyroid cancer, but it is an entirely treatable and curable disease entity. So people do not have to be worried when it comes to thyroid issues. Of course, very rarely we do see more severe thyroid pathologies, but thankfully that's a very rare phenomenon.
So it's important to think about those nodules and be aware of them, and then find someone who will follow them with you.
Yes.
See if they're getting bigger. Because you really can't tell yourself if they're getting bigger or not. It's hard to know.
Sometimes you can, sometimes you can't. So sometimes the thyroid will decide to grow in the neck, and so you may see people walking around with big, sort of bulky necks, and that's because the thyroid gland is big. But sometimes the thyroid gland decides to grow in the chest, and then you're not aware. But I have done surgeries where I've had to dissect the thyroid off the aorta, which is the biggest vessel coming off the heart. And I've had to do surgeries where I've had to split the chest in order to get the thyroid. So those can be tricky, and people may not always be aware of how extensive the thyroid is growing into their chest.
So you have a wonderful model. That model looks mostly at the soft tissues, things that are soft. And we also have a model of the skull, I see, with the hard tissue. That's really just a bony model. So tell us what we could learn from that.
Yeah, so this model, funnily enough, he's not really an occlusion, but this does show the bony anatomy of the head and neck. And really, I just wanted to demonstrate that head and neck surgeons also deal with bony pathologies, whether that's cancer of the bone, of the jaw, or the sinuses, or cancer that can even start in the soft tissue. If it grows enough, can involve the bone. We may need to cut out the bone, but then reconstruct it with a piece of bone afterwards in order to provide function and aesthetics. So, and it's not just cancer too. Recently I did an 8-hour trauma case with our facial plastic surgeon where almost every single bone that you see here was shattered from a trauma that the patient underwent. So it's not just cancer, we're also able to do trauma cases as well at Rumsey.
No, and that's marvelous. Again, so many people go for imaging studies, and as a neurologist we order CAT scans or MRIs, and the CAT scans specifically will sometimes show almost a hole in the skull. They call it a lytic lesion, of course. And we don't know what it is, and sometimes it turns out to be certain kinds of bone marrow cancers or other things. But just the idea that your specialty, you could actually take it out, hopefully get all of it out and cure the patient of whatever might be there.
Yeah.
And then basically be able to patch it up to the point where they could live a normal life, I think is amazing.
Yeah, thank you. Yeah.
Let's go into a new topic. I like the idea about the Inspire. So we all see, you've seen the commercial, I'm sure. They have a bunch of very older gentlemen who go around there with their masks on at night. And so many of our patients talk about having sleep apnea and wearing this contraption. And so many people complain about it. And there's another person there who looks very vibrant, who had a good night's sleep, who said that they use this device. And I don't know if it's the only device now available. You know, the FDA sometimes, and there's always variations, and there will be new devices, and they always make things better. But first, if you can give us just a little bit, what is sleep apnea? Because again, we think about more of that as a pulmonary or lung problem, where the lung specialists are looking at it, or your significant other says that you're snoring at night and not getting enough oxygen, or you're having these pauses while you sleep of breathing. And the idea of what is it? And when would Inspire be better? And if you think about it, you saw these older gentlemen wear these big contraptions, being very uncomfortable with it. And is this other person doing? Is the technology so much better that this other person is living a normal life, and everybody else is crazy? Why is anybody using the machine, the CPAP machine? So tell us a little bit about sleep apnea.
Yeah, so sleep apnea is a very common problem. The definition of sleep apnea can be a little nitty-gritty, but the basics of it is that when you're sleeping, lying on your back, you're obstructing your airway, thus obstructive sleep apnea, or OSA. And when you're obstructing your airway, you're depriving your body of the oxygen that it needs. And people may not notice it per se. You know, you may get, poor quality of sleep. You may wake up with headaches. Your bed partner may notice the snoring and the apneic episodes. But a lot of people do live with sleep apnea without noticing a whole lot. But you are chronically depriving your body of oxygen. And unfortunately, the implication of that is that you are much higher at risk for cardiac events, strokes, diabetes. And so it's a very important process to get treated. The first line gold standard treatment is the machine, continuous positive airway pressure, or CPAP therapy. So the machine, what it does is it blows air into your mouth to bypass this obstruction. And this is where this model, I think, kind of comes in handy. So the obstruction can happen anywhere along this pathway, but usually it happens when the tongue falls back and obstructs the pharynx. Now, Inspire, it is labeled as new, but really it's been on the market for 10 years, and it's a implantable medical device. So what it does is when the tongue starts to fall back with inspiration, it sends an impulse to the tongue through the hypoglossal nerve. So rather than it falling back, it sends an impulse to send the tongue forward. So it opens up your airway, relieves the obstruction, and treats the sleep apnea. So Inspire is very well tolerated, and a lot of patients are living with it very happily, and of course it does get rid of the need of you having to use CPAP as a therapy.
Is it for everyone?
There are certain criteria that you do have to meet for Inspire. So first is your AHI score, which tells us how severe your sleep apnea is. So you have to have either moderate or severe sleep apnea to be a candidate for Inspire. The other one is body mass index. So insurances will only approve if your BMI is less than 35 to 40. If you are over, that does not mean you can never get the device. We would just have to help you sort of get your BMI to a level that we can.
Lose weight.
Yes, lose weight, yeah. And then the first step towards determining whether you're a candidate for the device is I would have to take you to the operating room, and we do a minor procedure in the OR where we put you off to sleep, and I do a camera examination of the back of your throat to see how your throat collapses. If your throat collapses in the front to back direction, then you are a candidate for the device. If your throat collapses circumferentially, so all of it in at once, then you are not a candidate for the device. Thankfully, 85 to 90% of patients are candidates for the device. And sometimes, if you are not a candidate, there are things that I can do to kind of make you a candidate for the device. And then the second stage is the actual surgical procedure for implanting the device.
So for everyone who's interested in the Inspire, who might, and think about all the people who are using the CPAP machines, the idea is, would they go to you next? Would they go to the pulmonologist? I'm looking at patients and seeing things that for technology that's been out there for 10 years, and of course there's this commercial where people go directly to the consumer and tell them about it. Mm-hmm. I see so few people with the Inspire machine. And I'm trying to figure out what's limiting them. Is it the cost with insurance? Is it just they're too heavy for it, or something else? What, in your opinion? And again, so many people and so many of our viewers are listening. This is where they spent a half hour with us, and they're waiting for this answer from you. And they're saying, like, can my spouse, again, my husband, usually men have it more commonly than women, can they be a candidate? And this would maybe change their lives. Again, we're not promoting the Inspire, but just curious about any technique. So why are so few people getting this?
I will say, I will say it's becoming very increasingly popular. Like tens of thousands of people at this point have received Inspire as a treatment. I do believe there's a lot of hesitance when it comes to thinking that there's a device in your body for potentially the rest of your life. I will circumvent that by saying you can have it explanted if you don't like it. Thankfully, vast majority of people do like the device. And I think there's a little bit of misinformation out there too regarding the device itself that leads people to be very hesitant. So I would encourage people to meet a head and neck surgeon like myself in order to dispel some of that, fear or misinformation that they may have heard. Because it is a very well tolerated device, and I think it works extremely well for your quality of life as well, to treat this sleep apnea, get rid of the machine, and make kind of everyone happy.
Do you think there'll be, of course there always will be improvements to this, and over time, different machines that come out smaller, same way pacemakers, and again, this is not a pacemaker exactly, where it gets smaller, easier to use. Are you seeing the advances in that technology now also?
Yeah, there are. In fact, they're about to release a new model that is smaller. I will say, the model that we have right now is about this big, and that's the battery itself, and it lives in your chest. And then the second component is wires, which patients won't notice. It's implanted in the neck. So it's this big, it's buried in the chest, so you're not going to feel it or see it unless you're a very skinny woman. I think that would be a very skinny woman or man, I guess, if you don't have very thick pectoralis muscles.
And sleep apnea does occur in younger women who are very tall, almost model-like, thin women with very long necks. So it's a little bit different than you think sometimes. It
certainly can, yeah. But yeah, there's always advances with the technology, and I've heard that they're coming out with something that's a little smaller.
That's amazing.
Yeah.
I want to say thank you.
Yeah, thank you.
It's like a quick half hour that goes by. You've enlightened us about head and neck surgery, different procedures that are out there, things that we're really able to learn a lot about, and really that are locally available, whether you live on Staten Island, I'm sure all out through the tri-state area. These are procedures that are being used all over. I want to say thank you to everyone. I want to thank our wonderful group of producers. It's been a number of years. We've been doing this show for 10 years now. And I want to thank David, I want to thank Helene, I want to thank Sal for making us all look so good as they can. And again, thank you so much for watching us, and have a wonderful evening.